right now we have our injections and some biologic treatment options, as well as some knee preservation surgical options. So before we dive into those various treatment options, I think it's important to just touch on how we measure the effects of treatment. If we can't measure something, we don't really know if it's working, and so I want to just touch on a couple ways that we look at the outcomes of these treatments. So the first in our field, probably the most common way is just something called a patient-reported outcome measure, either PRO or PROM. And these are basically just survey instruments that we give to patients. You've probably received numerous different surveys after visiting a physician, but these are the purpose of this is to gauge the disease state as well as the response to treatment. These can be a general health survey, like there's the SF-12 that's looking at your overall health. Can be joint specific. So this survey at the top is the KOOS knee survey, and that's a survey with 5 different domains. It looks at pain, function, quality of life, activities of daily living, and ability to participate in sports, and all related to how that person's knee is functioning. And then also disease specific. So there's ones for cartilage injuries. There's an IKDC survey instrument that's pretty valuable for looking at these patients. And we also look at in sports medicine if patients are able to return to sport, return to their prior activity levels. So if we're treating a high-level athlete with a cartilage problem, one of our goals is to get them to be able to function at that level. Their daily pain may be secondary, but it's just when they're performing at their elite level, they're unable to because of their injury, and then our treatment needs to be able to get them back to that same level. There are numerous studies on these that validate for various conditions, and then so we'll mention a few of them as we're talking about specific treatment options. Those are the subjective evaluations, and that's valuable. Is the patient that we're treating, are they responding to what we're doing? The other side is an objective evaluation, and really this falls into 2 classes, either imaging or arthroscopic evaluation with a histological evaluation of the tissue. So for imaging, the most basic way is just with x-rays. So as knee arthritis progresses, we start to lose that space between the femur and the tibia. The cartilage wears, space gets more narrow, and we can track that on x-ray. It's not very sensitive to small changes. If you have a more focal problem, you're not going to pick that up on an x-ray, and it really takes time for arthritis to progress on x-rays. After ACL injuries, for instance, we start seeing degenerative arthritic changes on x-ray about 15 years after injury. So if we're trying to intervene with the treatment before that, we won't know our answer until 15 years later if we've made a difference. So one tool that I'm particularly interested in, and we've done a lot here at UCSF with, is MRI for looking at this type of disease and problem. So the MRI is a 3-dimensional evaluation of it's great resolution for soft tissue and gives us a much improved evaluation of anatomy relative to just those standard x-rays. We can also perform a quantitative MRI where we use sequences that are similar to mass spectroscopy, where we're looking at the biochemical content of tissue. So as we talked about cartilage, you have that proteoglycan content, you have that collagen structure, and we're actually able to measure that on MRI to understand if the proteoglycan level is changing, which correlates with arthritis progression. If that the collagen structure is changing, we can also pick that up with some of our advanced sequences. So in this color map, so we're looking at the knee from the side with the femur at the top, the tibia at the bottom, and these colored areas are the cartilage on the ends of each bone. Up here, this blue and green type of color, that's reflecting normal proteoglycan content in that knee. As we come through here, this red is reflecting abnormal proteoglycan, so they've lost that. And this is something where that joint space on x-ray may look normal. If you took a regular MRI, the tissue might look fairly normal, but we can actually pick up those subtle biochemical changes and use that as something to track our interventions in response to treatment, which I think is pretty interesting. The other objective analysis that we can do is a knee arthroscopy. So I showed a couple of videos of looking in the knee. We can go back in after cartilage treatment and say, did what we put in there, does it look like cartilage? We can probe it and say, does it feel like normal cartilage? And then we can also biopsy the tissue and send it to the lab, do our histology, and see if it looks like that normal hyaline cartilage. Downsides there, obviously, we're putting the person through another surgical operation. If it's just for diagnostic purposes, they're taking on those risks without potentially making a difference in their treatment. If we're doing histology, we're taking a biopsy of what we've tried to restore, which may be fairly counterproductive. So those arthroscopic evaluation, histologic evaluation, are really pretty limited in how to evaluate these. So as we move into treatment options, we'll start first with discussing injection treatments, and then after that go into more surgical treatments. So the first and most common injection that we use, and it's been used for years, but just a standard corticosteroid injection. And these medications, they're powerful anti-inflammatories, and then we can directly deliver them into the joint space. So if that joint is inflamed, you can take anti-inflammatory medications by mouth, those non-steroidal anti-inflammatories. You can take oral steroids, but then those effects are going throughout the body. So this is a focused, directed way that we can put it at the site of inflammation. They help with pain, they decrease inflammation. They're also expensive, they're safe, and they're generally effective. There are some downsides to steroids, though. I think a one-time steroid injection is very safe. For somebody trying to manage long-standing arthritis, it can be a good option if it seems to give good lasting relief. A recent study, though, that was published in JAMA, one of the leading journals in medicine, really, they looked at a randomized trial comparing steroid injections every 3 months to just saline injections every 3 months. And then they looked at those patient-reported outcome measures, and then they also looked at MRI to track the thickness of cartilage in the knee joint. What they found was for patients either injecting saline or that steroid every 3 months, there was no difference in the patient's perception of their disease state. So receiving that active steroid medication didn't really change anything. They did notice, though, that the cartilage thickness on MRI was decreased in that steroid group. So that repeated exposure, this was over a 2-year time period, but repeated exposure may be detrimental to the articular cartilage. It's a very sensitive tissue, and it seems this study and others show that there may be repeat injections may not be a great idea. So if that's the case, we need other options to try and treat these challenging conditions. And one that's fairly common also is hyaluronic acid injection. And They're synthetic medications that reproduce the normal fluid that's in the knee joint, the synovial fluid. The role of that fluid is to lubricate the joint, to nourish the cartilage, and the injection of that hyaluronic acid is thought to act as a lubricant to stimulate more normal production of synovial fluid. In the setting of arthritis, that fluid composition actually changes, and there's some thought that this may reset it to more normal type fluid. And then they're also thought to act as a strong anti-inflammatory agent, so just help with pain. This is one recent study that compiled results from a number of other studies, a meta-analysis, and looked at the response to hyaluronic acid injections over time, and can see that at the 8-week time point after injection, there's a reasonable effect size. People are feeling better. And then as we get further away from injection, that really tapers off. The evidence on these right now is fairly variable. For instance, our Orthopedic Surgery Academy, the American Academy of Orthopedic Surgeons, recommends against their use in arthritis, just that there isn't enough evidence to support the cost to use them. Some of the rheumatological organizations, they recommend using them. So this one is kind of a mixed bag on the true role. There's probably no downside to it, but it just is the cost of those medications, is that worth the benefit, the limited benefit that we may derive. So we still don't have a perfect solution, so we'll keep going. And there's a lot of interest right now in biologic injections. And these, the drivers, it's an attempt to harness our body's healing, regeneration potential to modify symptoms in the disease state. And these include platelet-rich plasma and stem cell injections. And so if you ever look up platelet-rich plasma or PRP, there is no shortage of what it can do. It will get you playing golf like Tiger, tennis like Rafael Nadal, saves careers. It will get you back in the game. It'll give you a better self-image. Basically anything you want, it can do. But we'll try to look a little more at some evidence and see what's realistic. So first, just very basically, PRP, it's a volume of plasma with a platelet count that's higher than normal whole blood. So the platelets, they're important in clotting for the blood. They're a component of our normal blood, and then this platelet-rich plasma is just the plasma component with an elevated platelet count. The thought is that there's various growth factors that are present in what's called alpha granule, which is a component of the platelet inside that cell, and those growth factors may be useful in diseases, inflammatory conditions like arthritis, tendinitis, etc. And we can exploit these as a powerful directed biologic treatment. Really recently there's been an increase in the clinical utilization. So this figure here, so we're looking at the baseline percentage, and then these are all growth factors that have some role in cartilage health and inflammation, and we're able to deliver those all at a higher concentration with this biologic treatment. So one thing though is that not all PRP is the same. These figures here, these are just 6 different systems. They're all made by a different orthopedic device company, and they all have a slightly different preparation protocol. You spin the blood in a centrifuge. The spin rates are all a little different, and as a result, the end product is different. We can also prepare it specifically with different variables, including the presence or the absence of white blood cells. That'll be important on the next couple slides as we talk about PRP for knee arthritis. But some of these systems you can exclude white blood cells or keep them in depending on what you want to treat. And then we can also leave a fibrin architecture, so meaning that we can make this as a gel or a more solid substance that can be used in surgery. You can put it directly where you want, versus the ones without the fibrin architecture, so that's something that you could inject instead. It's also important when we're talking about the variability of PRP that it varies from person to person. So all of our blood is going to be slightly different, and the concentration of growth factors, the overall composition will be different if we look at 2 people in this audience. They've also shown that that concentration can vary depending on what time of day you draw the blood. Different concentrations in the morning versus afternoon. If you've had a high-fat meal recently, that can alter the concentrations too. So when we talk about using PRP, also I think it's important to realize this isn't like, I'm going to take Advil, I'm going to go to the drugstore, I'm going to buy Advil, and that bottle's going to be same as the next, because we can standardize the preparation. Here, we don't always know exactly what we're putting in, which increases a lot of variability in, I think, our results that we have. So to prepare PRP, we start with a blood draw, and just take anywhere from 30 to 60 milliliters of blood, usually, depending on the system again. It's then placed into the centrifuge, and the blood goes through 1 or 2 spin cycles to spin down the elements, so you're able to isolate the layer with the plasma and the platelets. And then this is what that final injectable looks like. And so here, that 30 to 60 milliliters of blood is now concentrated down to, you're pulling off 5 milliliters, and that's able to be injected for local delivery. So some studies on the role of platelet-rich plasma in arthritis. I think this is one of the better studies on the topic, and from one of my mentors that I was able to train with. But comparing hyaluronic acid and platelet-rich plasma, this was a double-blind, randomized control trial, so neither the person injecting nor the patient knew which one they were getting. So really our highest quality of evidence for this type of study. And they took patients with mild to moderate knee arthritis, tried to recruit everybody that came in, and then always whittle it down to a much smaller number. But they were able to randomize 111 patients between these 2 treatments. And what they found was the outcome scores between PRP and hyaluronic acid. If you look at just the WOMAC score, which is one of those survey instruments that reflects pain in the knee, there was really no difference between the 2 groups at 6 weeks, 12 weeks, 24 weeks, or at 1 year. If you look a little further into the results, I think a few interesting findings that they point out. But one of the really nice things that they did was they actually took synovial fluid samples periodically through the study, and they were able to look at the inflammatory molecules in the knee joint fluid to see if these treatments were influencing that at all. What they found was early on in this 6 to 12 week time frame, the inflammatory cytokines, the chemicals in the knee, they were lower in the platelet-rich plasma groups. So it seems like this had some effect on limiting inflammation in the knee. And then one of their outcome measures was the IKDC score. So that's a knee-specific outcome that reflects a little bit more about activity. It's not just focused on pain. And it was consistently higher in the PRP group compared to the HA group across really all time points. And so what they found was, or what they concluded from this is that the PRP worked better for mild arthritis, and then also they found that patients with a lower BMI, so a lower weight, seemed to have more of a positive response. They did find that these lower levels of pro-inflammatory cytokines, so I think that this is really one of the more interesting things from this study, that we're able to introduce what we think is an anti-inflammatory agent, and they're able to directly measure that these concentrations are lower, that we're having that what we think is that effect is happening. And then patients were able to likely keep going at a higher level of activity. Their pain may still be at a similar level, but they're performing at a higher activity level relative to where they were before. So kind of mixed results, but some mild to moderate benefit of PRP over hyaluronic acid. There have also been a number of recent systematic reviews. And so a systematic review is where we pool multiple studies in the medical literature and try and take these smaller studies. They're looking at 20 to 100 patients, group them all together, and then see with that are we able to notice any trends that you may not pick up in those smaller sample sizes. These systematic reviews have all included level 1 and level 2 evidence. So that prior study, that double-blind randomized control trial, that's a level 1 study. That's the best that we can do. Level 2 is just short of that. A couple differences, but also very high-quality evidence. And across these studies, what we see is that the platelet-rich plasma, the results do seem to be a bit better. They're not overwhelmingly better than what we see with hyaluronic acid. In this study, they're looking at breaking it down. So we mentioned that you can have these different compositions of PRP. You can have it with white blood cells and without. And what they found is really that leukocyte poor, so no white blood cells in it, that's the one that really seems to be having the better results. And if you look at just that, you see a positive effect. If you include the studies that also put white blood cells in there, then it kind of washes out. And that previous randomized trial, that was looking at the PRP without the white blood cells, so in line with that finding. Here, we're looking again, PRP and control injection, and interpreting these odds ratios. This black diamond is summarizing all those results. If it crosses this midline, then there's assuming no difference between the groups. Here we're a little shifted to the right, but again we include that middle line that would say no clear statistical difference between these groups. So overall, looking at all these various studies, it does show that they favor PRP with a modest effect, but none of these are able to look at the natural history of patients with knee arthritis treated with this platelet-rich plasma. So I think at this point, when looking at platelet-rich plasma treatment, there's a possible benefit from this leukocyte poor, so no white blood cells, PRP. The results seem to last about a year. I don't think there's any evidence to support structural regeneration. This is not going to regrow cartilage, restore meniscus, anything like that, but it may work as an anti-inflammatory, help with symptoms of activities. We don't have any long-term data yet on the natural history. So then next type of biologic injections, so stem cell injections. We've included quotation marks around it because we're not always sure exactly the stem cell concentrations. But so mesenchymal stem cells, they're cells within our bodies that have the potential to differentiate into cartilage, bone, tendon, and muscle. And the thought is that if we put these cells into that joint environment, that they may allow for targeted regeneration of tissue. There's also the thought that these cells themselves are strong anti-inflammatory agents. And the mesenchymal stem cells, we find them in our bone marrow and also in our fat. And so two common sources, this is showing withdrawing fat, so basically like a liposuction procedure. Withdraw fat from the abdomen and then spin that down, concentrate it to a liquid form, and then able to inject that into a targeted location. And then this is withdrawing bone marrow from the pelvis, from the iliac crest, which is a good source of bone marrow. So outcomes of stem cell injections, there is very, very literature at this point, very few published studies on this topic. This is one study that looked at outcomes of stem cell injections for knee arthritis over a 2-year time period. And they looked at a low dose, medium dose, high dose, and then tracked the WOMAC scores, that reflection of pain, and then just a pain score over 2 years. And people got better. But the problem here, there's no control group. This isn't comparative, and the patients all know that they're receiving this. We know that's very, very powerful. We also know that with time treatment, arthritis can get better. Compare this to, this is a randomized trial of going in arthroscopically, cleaning up the joint, versus doing a sham surgery where they put incisions on consenting patients but no surgery, and then just follow those patients. And everybody got better, stayed better. It really follows a similar trajectory of that stem cell treatment. So we really need better studies that compare to control groups, to other available treatments before really drawing conclusions. And then there's a lot of interest in general on this topic. I think this was published 2 or 3 days ago. It's this week in the New York Times. And the stem cell clinics are popping up everywhere. The FDA is looking to probably regulate a bit more. They haven't done too much yet. And it's an area that a lot is happening, but the evidence, it's really not quite there to support these treatments, in my opinion. So for the current state of biologic injections, platelet-rich plasma, I think there may be some benefit in mild to moderate arthritis, but it's important to remember that there are variations in preparation in the composition that we'll get, and we don't always know exactly what we're injecting. The stem cell injections, I don't think there's any available data right now to support widespread use, and these treatments are often costly, but not paid for by insurance, or $5,000 to $10,000 out of pocket, and I don't think that we as a group can say, pursue this will regrow cartilage, this will make a difference in the long-term progression of arthritis. I do think this is a fairly exciting area, though, and further, I think clinical research is really needed in this area to understand the role of these treatments. One final injection in class of injections. So the field of rheumatology conditions like rheumatoid arthritis have really been changed by disease-modifying agents. And these are, for rheumatoid arthritis, either an injection or a medication, and it stops the systemic inflammatory process or modulates it. And you're able to alter the disease course through these immune pathways and really limit the devastating effects of conditions like rheumatoid arthritis. There's been more interest recently in developing similar treatments for osteoarthritis. One such treatment is from a company named SamuMed, and this is one of the research studies that we're doing here at UCSF, but it focuses on inhibiting the Wnt pathway. And so that pathway, as outlined here, is important in cartilage degeneration, regeneration, and they have a molecule that can be delivered through injection into the knee and may be important for treating pain associated with arthritis. There's also some early animal studies that show that it may have a role in cartilage regeneration too. So this may be having its desired effect. It's gone through a phase 2 study with the FDA so far. It's been shown to be safe, and then we're helping understand, does this help with symptoms? And we're also going to be looking at repeat MRIs after injecting this to see, is this changing the cartilage? So like we saw in that steroid study, perpetually putting in steroid, that cartilage gets thinner and thinner. We're hoping something like this. We inject that one-time injection, and then may see some cartilage regeneration even. So I think this is a pretty interesting class of medications that we're looking into a bit here too. So next, we'll move into surgical options. And for the surgical treatment, so going back to our classes of different types of degenerative or issues in the knee, so widespread disease, probably not a great surgical treatment for restoring cartilage. We're not able to resurface the whole thing. But if we have a focal cartilage injury, just one spot, then we get a little more interested that we can help that with an operation. So the first and probably the simplest option that we will use is a marrow stimulation procedure. So this is microfracture, and this procedure is done arthroscopically, and you essentially use an instrument to poke holes into the subchondral bone. And so that bone underlying the cartilage, there are the mesenchymal stem cells, the MSCs, in that layer, and by poking the holes in there, you're able to bring those elements out, and then the hope is that they fill in that defect with new tissue. The area of cartilage loss is then filled with fibrocartilage. So going back to our histology, we talked about type 2 collagen being the primary collagen in hyaline cartilage. This repair tissue has type 1 collagen, and the downside is it's not as durable as our usual knee hyaline cartilage, but it's better than having no cartilage. It's also nice because we do this in a single operation. We'll talk about a couple others that require multiple operations, and then the surgical instruments, they're readily available. This is a fairly quick, easy, inexpensive procedure. And then the downside is that it fills with fibrocartilage, not as durable as normal cartilage. So works, but hopefully we can do better. One study here that is a pretty nice evaluation of microfracture. So looking at 48 patients, minimum 2-year follow-up, what they found is that about 2/3 of their patients had good or excellent outcomes with this treatment. So it means 1/3 either fair or poor. The outcomes, when they look back on imaging, they're related to how well that defect fills in with the fibrocartilage. And these figures here, this top one is showing different scores. So an activities of daily living score, the SF-36, and also just a subjective rating, and how that relates to either a good fill in black, the moderate in the light gray, and a poor fill in dark. So if we can get a good fill, which we can't always control perfectly surgically, but that leads to a good outcome. And also patients with a lower BMI, so lower weight, they had better outcomes in general. So then another option for surgically treating these lesions is, or another class is a cell-based treatment. So one of these that's FDA approved and fairly commonly used is called matrix-associated autologous chondrocyte implantation, or MACI. And this procedure requires 2 stages. So the first stage, we go in arthroscopically, and we take a piece of normal cartilage from the knee. And they want us to send 2 Tic Tac size samples of cartilage, so really small, and we're able to do that minimally invasively, outpatient procedure, fairly easy to recover from. And then we send that tissue off to their lab, and there they grow that cartilage in culture, and they're able to give us back a disc with some matrix and those chondrocytes on it. So we're taking the patient's own cells from cartilage, and then we're regenerating new tissue. They're able to send that back to us, and then we're able to implant that surgically. So this is a patient with, this is looking at their kneecap, and this is an area of missing cartilage. So you can see the smooth white through here. The purple dots are surgically to outline the bad area, and then that's just a missing piece of cartilage. And then on the right here, this has now been filled by that regenerated tissue. And one advantage here is that we're replacing articular hyaline cartilage. They've done studies that look, it's not quite as normal, but it's better than that fibrocartilage that we get with microfracture. You do need normal bone underneath, so we're just resurfacing the lining of it. And so if there's a large pothole of bone, just repainting the top of it's not going to change that underlying bone problem. So what are results like with this treatment? So there have been a number of studies. This treatment has been around in various iterations since the 90s. And this is one where they randomized patients to microfracture or this MACI, this cell-based treatment, and found that the results for MACI, so this is looking at function, looking at pain, and the various scores are outlined here. And then at 2 years and at 5 years, we see better patient-reported outcome scores in this cell-based treatment relative to microfracture.